Welcome to Gyan Pravah series episode 239, which is the brainchild of Fogsi President Dr. Sunita Tandulwadkar Madam. She has started so many projects during her presidential year for the welfare of the women, like Sampurna, Do Tike Jindagi Ki, and for enhancing knowledge to medical practitioners like Eagle Project and other many projects. KYN is another very important project to know the health status of the women in our country. She has been awarded MRCOG recently and also Presidential Award by past President Sri Ramnath Kovindji. Madam needs no introduction. She is the head of the department and chief of IVF Endoscopy Center, Ruby Hall Clinic, Pune.
Thank you, Kavita.
Okay, Madam has credit to some awards that I am mentioning: IVF Icon of the Year, Pride of Fogsi, Bharat Gaurav Puraskar, Best Medical Practice, Best Citizen of India Award, Glory of India Award, Punyashloka Ahilyabai Holkar Award, Rashtriya Gaurav Award, and later appreciation from President India 2012 and Sarvasri Award 2012. She has been invited as a faculty to 400 plus national.
Kavita, that's okay. Today is your day with Dr.
Yes, madam. Okay. So, just today's topic is mental health and menopause, and for this, the guest speaker is Dr. Nilanjana Mukhopadhyay. She is consultant in OBG, Luton and Dunstable University Hospital, Luton, Associate Medical Director for Rehabilitation, Luton and Dunstable Hospital, Honorary Senior Lecturer, University College London, Member Standing Committee, European Board, OBG, Examiner, MRCOG 3, RCOG London, British Menopause Specialist, Recurrent Miscarriages Leadership, and Performance Coach, East of England Network. She has been affiliated FRCOG, RCOG London, September 2013, and FICOG by RCOG in February 2012. She has done Masters in Medical Education from Dundee University, July 2021, and Diploma in Claims Handling and Risk Management, London, 2009. And she has done DJO from Patna and MBBS from Patna. And I and Dr. Nilanjana are batchmates. We have studied together in PMCS. That's why I could invite today. And she had major achievements like past year Part 1 MRCOG and many RCOGs posts, publications more than 50, and has edited more than 5 books. She has been in editorial board 2 times and presentation national as well as international more than 100. She has Excellence in Medical Education Award, UCL, PMG Award, and Clinical Excellence Award. So topic is mental health and menopause. So madam, you want to listen or you just want to bless? Yes, I will say.
Kavita, as our protocol is, I'll join the viewers link to listen to both of you. I'm here just to share my respect to madam, and thank you so much for coming on a Fogsi platform. It's a pleasure and it's an honor for us. It was wonderful listening to you. I think mental health is such an important topic, and that's why today we have now our publication on mental health at perimenopausal and postmenopausal age. It's just a data collection which we have done, and I'm sure you will be able to guide us when we are writing the publications. I will tell Dr. Priya Gupta to be in touch with you. Yeah? And thank you so much. Here. Thank you.
It's my real pleasure. Thank you.
Thank you, Kavita. Thank you so much. Bye. So much. Enjoy your podcast.
Okay. Thank you, madam, for joining. So just before we start, I want to say about a few sentences about the topic. Menopause brings significant physical and mental changes due to declining estrogen level, which can lead to mood swings, anxiety, depression, irritability, and cognitive issues like brain fog and memory loss. The interplay between hormonal fluctuation and mental health is complex and bidirectional. Estrogen exerts neuromodulatory effects on brain, while progesterone has anxiolytic properties via its metabolite allopregnolone, which enhances GABA receptor activity. Now, with increasing life expectancy and because of nuclear family, more women are facing such mental issues. So let us hear from Dr. Nilanjana Mukhopadhyay. She will tell about how we can face these challenges and how can we overcome these problems so that we can lead to a useful and healthy life. So before this, you want to say anything, Nilajna, or should we start the questions?
No, we can start because I think I will be able to cover everything during your questions. Thank you.
Thank you so much. So just I want to know, what are the main symptoms of perimenopause and menopause?
So, as most of us know, perimenopause is the phase preceding menopause, and this transition can take many years for some women. And there can be a variety of symptoms that women can get. So if I go back to the 2019, some of my data is UK based, but I'm sure it is pretty similar in other countries as well. So there was a UK Chartered Institute of Personal Development Research survey, and they looked at women between 45 and 55 years of age. And they found that the most common menopausal symptom during this phase was hot flushes. Nearly 72% of them reported hot flushes. 64% women will complain of sleep disturbances. And 58%, so more than 50% women complain of night sweats. 6 out of 10 women were affected by these symptoms at work. 65% said they were not able to concentrate. And more than half of women can experience more stress, and they feel they have less patience with colleagues. Now, you mentioned brain fog. This cognitive impairment is quite common, and that can affect over 60% of women. There is also an important manifestation of depression and anxiety, which I think is really important as gynecologists to be aware of, because this can affect women quite severely. And we'll talk a little bit more about that in my subsequent slides.
You've already mentioned what are the mental health symptoms that women experience. Most of the things have been covered, but you want to add anything?
Yes, so amongst the mental health symptoms, which is what we are focusing today, because menopause is huge. So we'll just focus on mental health today. And I want to point out the main important mental health symptoms that women can experience are cognitive and mood changes. The second one is major depressive illnesses. And the third one is anxiety and depression. And then I want to really touch upon a little bit on bipolar disorder, suicidality, and dementia and Alzheimer's disease. But because there are lots of studies looking into all of this, whether estrogen can prevent some of these long-term conditions which can affect women in later life. So the main things really are cognitive mood changes and major depressive illnesses.
Yeah, I think besides hormonal disturbances, the women think that they are being lost. They're just like the term emptiness syndrome, that children are outside, even husband sometimes had a divorce or husband is no more. So she thinks there is no one to look after. So these can affect their moods more than the only hormonal changes. So this is very important thing which we should consider while talking to the women with menopause. So how do changes in estrogen level during menopause impact mental health and mood? So what do you think?
So how does estrogen cause help with our mental health? It's so important to understand that this estrogen is such an important hormone that regulates the metabolism, and it increases the cerebral blood flow, and it causes dendritic outgrowth. It also increases some nerve growth factors through co-localization of receptors, and helps with neurotransmitter synthesis. So there is some link between the neurotransmitters in the brain. I don't think we know exactly how estrogen does it, but we certainly know that the estrogen does help with increasing blood flow and nerve growth. The evidence for long-term and objective changes in cognitive function and mental health, it's slightly less clear. I don't think we have still got good evidence. But as you mentioned before, there is a domino hypothesis So women in this stage of life are juggling 100 different things. They have got aging parents, growing children, a very high profile job or responsibility in jobs. And they are kind of juggling all of that together. And in that, they can also lead to lack of sleep and all the other symptoms that can come. So the domino hypothesis asserts that vasomotor symptoms, which we talk about, is hot flushes, having excessive perspiration, worse in the nighttime, and that also leads to disturbed sleep, which could mediate effects on cognitive and mood function. So if somebody can't sleep at night, they get up in the morning and they feel grumpy, they're not in a good mood. So this is the domino hypothesis. And we know that hormone treatment, particularly estrogen, could potentially reverse some of the psychological issues. However, the evidence in long term is still inconclusive from the studies.
So I think you have already mentioned the effect of menopause on cognitive changes. So how can we correlate cognitive changes with estrogen levels? What do you think?
So, very interesting question, because cognitive changes are associated with menopause transition. We talked about it. And we said that this cognitive decline mainly affects the verbal memory. So kind of mental fog, forgetting names, forgetting things. It's in your mind, but you just can't say it. Attention and working memory. But when we look at the cognitive function, it does not change linearly across the menopausal stages, because we know that the main cognitive effect happens in the first year after the first missed period. Yeah. So once the period stops, the first year is the most affected. After that, it actually kind of gets better. That change is not seen so much. And there was a Swedish longitudinal study which showed that the verbal fluency, which women sometimes talk about, it does show a slight decline across the years after menopause. But it is independent of the chronological age. So for example, for you, it may be 60, for somebody it may be 45, for somebody it may be earlier 40. So this does not follow a pattern of chronological age. Yes. But also remember, cognitive changes is not just because of estrogen. It could be because of many different things. So people who live through war and famine and have got starvation as in childhood. Yes. These women will have cognitive decline more than women who live with good nutrition and good diet. Yes, exactly. And the environment. Women who have been exposed to different type of contraceptives may also have an early cognitive decline. Then think about those women who have had hysterectomy, and we should cover that hysterectomy in this, because women who have hysterectomy will have some menopause. Effect.
Yeah, surgical menopause. Yes. And the cognitive change.
And then, of course, lifestyle. For example, people who smoke and who drink too much alcohol. This is also an additional factor which affects cognition decline. If you have a very sedentary lifestyle, for example, you don't do much work, you're sitting at the desk and working, then that has an effect as well. And in countries where people don't have to walk, they just drive in their car and do very little exercise, that has a direct link with cognitive decline as well. So there are many factors which will also affect this cognitive decline, in addition to the menopausal changes with drop of estrogen.
I think, Niranja, what was in India, that is village culture, village life, that was very good, because women used to talk to each other. They used to share everything, like in Chapal and Panchayat. So they were not connected to globally, but they were connected to each other much more than today they are connected. today
And they
we
were
all
physically
connect to-
active as well.
Yeah, so that's why, and they used to work hard. Physical work is very important. For only for cooking for one meal, they had to bring the wood, they had to prepare everything, they had to bring water from the well. So all these things, I think the mind was so much occupied that they were not able to think about these things. So nowadays we are facing so many problems. We have not seen any our grandma suffering from these problems. Nowadays you are seeing so many problems. So I think the lifestyle and culture that has also brought so many changes. So should women who have hysterectomy at an early age be offered HRT?
So before we go on to that, I think you asked me about the estrogen levels. Sorry, I didn't address that. So the question is, I think what you're trying to say is, if somebody has significant cognitive changes, does that mean that their estrogen level is very low? Actually, it's very interesting that cognition and mood during menopausal transition only shows a decline in women who are of normal weight. So in women who are overweight and obese, who have a BMI more than 25, they actually have slightly higher estrogen level, which is coming from the adipose tissue. So to some degree, they are protected from the cognition decline. But there is no association between estrogen level and cognitive change. So you can't measure the estrogen level and say, oh, your levels are very low and you should not, you will have more cognitive changes. And we know that actually, apart from estrogen, it is the sex hormone binding globulin. Do you do that in India?
No.
So sex hormone binding globulin. So we know estrogen is a lipid soluble substance. So it cannot be transported in the blood unless it binds to a protein. Yes. So majority of estrogen is bound to sex hormone binding globulin and to albumin. But if you have very low level of sex hormone binding globulin, then your free estrogen is high. And if you have, so you can understand, so if your sex hormone binding globulins are very high, then the estrogen is all bound and you have less of free estrogen. So some researchers suggest that sex hormone binding globulin is a better marker of showing the low estrogen levels or the high estrogen levels.
Yeah, free estrogen will be measured by
exactly. That is how you can measure it. But if you did gonadotrophin levels, for example, FSH and LH.
We do FSH, we do.
So FSH and LH are more reliable indicators of menopausal status. But those, you can't really do them for once somebody is menopausal over 30 of FSH or LH, then I don't think you have much information by doing that blood test. Interestingly also,
we offer HRT in these women who had gone hysterectomy, I think at the earlier age. In India, you know, many women, especially by surgeons, whatever they have complained, even some void discharge, surgeon will not see what is the problem, they will do hysterectomy. So if the woman is has undergone hysterectomy at an earlier age, like 30s, so should they receive HRT? Because
yes, so surgical menopause, which really means so there are two groups of women. You are doing a hysterectomy where you remove the uterus and the fallopian tubes. And there is a group of women where you are doing a hysterectomy and you're removing both their ovaries as well. Okay, so if you removed just the uterus, then it's not a true surgical menopause. But they don't have periods, but they will still have the estrogens. Now, if you did hysterectomy at an early age, so in their 30s and early 40s, these women can have a significant cognitive decline much earlier. Now, when we look at, there's a big study in Denmark, and they looked at women who had hysterectomy with or without oophorectomy. So say you did a hysterectomy on somebody, and they said that just doing hysterectomy increases the risk of early onset dementia by 38%. But if you removed one or both ovaries, then that risk doubles. So nearly, 70%. So even if you leave one ovary behind, you're still putting this woman at a risk of early dementia, Alzheimer's, etc.
Actually, hysterectomy should not be done in these women. But in India, still surgeons are doing more hysterectomy as compared to gynecologists. And they don't think about these things and they will remove the ovaries. So that is major problem in our part at least, not in your. So they are having such type of problem. Many women come at earlier age and they are having such menopause.
So each year of early menopause. So if somebody has a hysterectomy at the age of 40, so they have like 10 years of early menopause, yeah? That relates to, each year correlates to 6 months of cognitive aging.
Yes.
So they will have 5 years of early, so they have their cognitive aging, which starts within 5 years. So every year correlates to 6 months of cognitive aging.
So then in these women, we should offer HRT. That is better.
So yes. So the answer to your question is yes, because when women have an earlier age of surgical menopause, we should protect them with hormone replacement up till at least their natural age of menopause.
Okay.
Now, that is usually 51 in this country. I think in the Indian population in the UK, the average age of menopause is 5 years earlier. So it's 46.
Yes. Yeah, 46.
So I think in India, it'll be a little earlier. So women who have hysterectomy or a menopause which is early should be protected with HRT, because it'll help with their bones, so keep the bone mineral density, and cardiovascular benefits as well.
So what type of HRT do you think should be given? Because we have to, naturally hysterectomy has been done in these women, but still they can have breast malignancies also because of unopposed HRTs. What HRT you prefer to offer to these women who have undergone?
So women who have hysterectomy, we need to first look at what is the indication for hysterectomy. So all women who have had a total hysterectomy, so they don't have the uterus or the cervix, do not actually need progesterone. So we give them unopposed estrogen, and they can have transdermal estrogen, which is the safest, as we know now. So transdermal estrogen comes in patches, gels, sprays.
Yeah, this is available in our part.
And and they are much safer when looking at the data that we have in terms of breast cancer and thrombosis. But if any woman has had a hysterectomy and her cervix is left behind, then she should really also receive progesterone, because we cannot give them unopposed estrogen. And the second most important thing here to remember is, if somebody has had a hysterectomy because of major endometriosis, stage 3, stage 4 endometriosis, these women should be also given progesterone, because the endometriosis, which is peritoneal or on the bowel, can also flare up with estrogen, and hence that should be combated with the use of progesterone.
Nowadays, many women, even without surgical hysterectomy, are having premature ovarian failure. So we have seen so many women. So what do you think? They should also receive HRT?
Yes. So really the benefits of hormone replacement therapy far outweighs the risk when you think about women who are in their late 30s and early 40s, because of the protection they get with their bones and with their cardiovascular health. So any woman who has been diagnosed with premature ovarian failure should be offered hormone replacement therapy, or even and combined oral contraceptive pill works well in some women, maybe even up to the age of 45. But after that, you can change it to a HRT preparation. So they should really be given hormone replacement therapy. Of course, it is a discussion you have to have with your patient.
Yeah.
Yeah.
And they should have undergone all the tests earlier before starting ERT.
Yes,
Like
yes, of course. It's once you've made a
yeah,
diagnosis.
ultrasound, everything should be done. Yeah. So, what about major depressive illness in the women of menopausal age? So already you
Yeah,
mentioned
this is a
that
very interesting question, because we are seeing all over the world, women are being diagnosed with major depression in this age group between 45 and 55. So if we look at the global population, nearly 6% of the global population each year are diagnosed with depression, major depression. And twice as much women are diagnosed as men. So as gynecologists, we need to be very conscious and we need to be asking these questions. We don't know why women are affected more than men, but we know that the estradiol variability, so during the menopause transition, the estrogen is going up and down. This has a close relation to mood changes. And we also know that during this time, as I explained earlier, there is it coincides with substantial midlife stress. You know,
yes,
like aging parents, growing children, problems in the family, health conditions, transition in their roles and jobs, and all of these things increase the vulnerability to depression. So, as gynecologists, it is extremely important that we keep an eye on this. Now, more so, I don't know how many gynecologists would ask the history of previous depressive illnesses. So, the things we need to ask: have you experienced postpartum depression? Have you experienced feeling low mood anytime before? Because if somebody has a history of depression before, they are quite likely to go into a major depressive illness during this transition.
yes, right. So if any woman has faced depression in any form earlier, they are more
Yes.
likely to go into depression, just like
Yeah.
gestational diabetes. Anyone who has
Yes.
suffered, they are prone to
So
be
it's
fat.
very important to take
Yeah,
that history.
yeah. Nilanjana, can you talk to us about the evidence from SWAN study from US? So what is the SWAN
Oh,
study?
I'm really pleased you asked about this, because this is a really one of the only studies which looked at women of different ethnicity in their menopause symptoms. So this is the study of women's health across the nation, so SWAN. It wasn't a very big study. This was based in the US, and about 500 pre and postmenopause, perimenopausal women between the age of 42 and 52. But they all had an intact uterus. So all of them, nobody had hysterectomy, and none of them had hormone replacement therapy. So they were followed up for 13 years, and they asked them about all their symptoms. And the interesting thing was, because it came up with a lot of findings which were really interesting, and they showed that while we are talking about major depressive illnesses, that increased risk of recurrence of major depression is significant. But if somebody has never had any depression before, it's very unlikely that they will get a new depression diagnosis in menopause. So if you see somebody and they say to you, I've never felt like this before, I've never had any depression, I've never felt like this, then you need to get some psychiatric help, because this could be something different. You should not think that this is related to
Depression.
estrogen deficiency. Yes.
Sure. So I think here is the role of psychiatrist or
This
psychologist.
and this study also showed, interestingly, because in the US they didn't have very many Chinese or Indian women in their population, but they had quite a big population of Black women. And they actually found that Black women had a much more likelihood of suffering with significant symptoms. And these women did not seek help, because they felt they can't talk to anyone, they can't go and seek help, and they suffered in silence.
Yeah.
And in this Black and Afro-Caribbean population, the transition can be quite long. So they can have like 10 years of perimenopause. And they have, the study very clearly showed that there was also clinicians who were giving less HRT to women of different ethnicity than the white population. So that is the reason this study was, is one of its kind so far, where they have looked at ethnic diversity and how menopause affects different women from different ethnicity.
Okay, so we should know about the SWAN study also to know the mental health of the woman.
Yes.
So now I want to ask, are women more likely to have anxiety symptoms at menopause as compared to reproductive age group?
Yes. So the early and late menopause transitions are associated with increased risk of depression and anxiety. So what do I mean by that? So somebody who has an early menopause and somebody who has a late menopause, they have a longer transition. So it is the phase of perimenopause. You know what? These days, perimenopause is more important than menopause because it is that transition, and that is when patients get all the symptoms. But patients who had low anxiety before menopause, they are actually at increased risk of anxiety during menopause. And this, the SWAN study showed that. And then you may have heard of another study called the KEEP study. This was the Kronos estrogen study on heart. So they were only looking at the heart and cardiovascular effects, but they actually got additional information which showed that estrogen reduces anxiety and depression. So the group of women that they were giving estrogen, but they were only looking at cardiovascular effects, but they got this additional information that it actually helped with their mental health condition. So it is really important that as gynecologists, when we do our history taking, we always ask about mental health, about depression in the past, history of any family history of depression, family history of anxiety, postpartum depression, anxiety, psychosis. Taking that history is very important.
Yes, right. She should be inquiring every woman who has come to us for any symptom during menopausal or perimenopausal age. So, is there any evidence for bipolar disorder to manifest in menopause or during perimenopausal period?
So no, the answer is we do not have any good studies that have investigated into psychiatric or psychotic symptoms in women with bipolar disorder. But we know that menopause transition is a vulnerable period for a lot of women, particularly those who have psychosis or schizophrenia or bipolar disorder. They can get a relapse in this phase, but we don't have evidence on this.
As such, bipolar disorder is not a
there's no effect of menopause on it. Yeah.
Okay. Okay. What about the evidence of suicidability, as we see more women perimenopausal dying of suicide? So they are so vulnerable that even small trigger make them attempt to do suicide. I have also seen a woman, she suicided for a smaller reason because her children were not taking care of her, and for that, lastly she did suicide. So that I have faced, I think, 8-9 years back. So what do you think? What is the evidence?
So even in the UK, we have seen that women in their menopause transition, so in their late 40s and early 50s, there is a slightly higher risk of suicide in women. And we know the midlife is a time of elevated risk for both sexes, men and women, but particularly the risk is higher in women. But we don't have good quality, robust studies looking at this. So we don't really have substantive evidence between attempted or completed suicide and menopause transition. So no really good studies to show this, but it is a trend that we have also noticed within the UK.
I think the woman, if she's alone, she has not any support from any children. Maybe her husband no more. Just I have seen that woman who was alone. Her husband, I think, died a few years ago, and children were not very supportive. It may be reason that she did committed such heinous crime. I don't know what was the trigger, but I have seen it just 9-10 years back. Maybe the cause was maybe another thing. It's not a characteristic of perimenopausal transition, but I have faced one case. So about 9-10 years back, of course, I don't know because she left us, so we don't know. So there are some studies showing increased incidence of dementia and Alzheimer's disease in women with early menopause. Is this true?
So, yes. So, women with early natural menopause, so women who have an early premature ovarian failure less than 40 years, there are studies which show that they have a higher risk of all-cause dementia. So these women can have dementia later on in life. And women who have a menopause after 55, do you see many women who have late menopause in India?
Nowadays, we are seeing, especially those who are obese in affluent families, they're
Yes,
having
so
late.
obese women, yes. So these women who have the late menopause, they have a lower risk of dementia. So we have certainly seen that. And
Maybe
then, as I
because of
mentioned
estrogen.
earlier, surgical menopause. So say somebody had a hysterectomy at an early stage, they have a 10% risk of dementia. Do we tell all our patients who we do hysterectomy on, do we tell them that you have a 10% risk of early dementia? We don't. But I think this should be discussed with the patient when we offer a hysterectomy. And then if you look at women who have had early menopause and never took hormone therapy, they also have an increased risk of Alzheimer's disease. But as I said, earlier, apart from age and hereditary risk factors, there are multiple acquired and protective factors as well. So Alzheimer's and dementia, hormone is not the only cause, but there are lots of other protective and hereditary factors and lifestyle factors. So I think it's important that we think about hormone replacement therapy in women who have an early menopause or an early hysterectomy, but hormone is not the treatment for dementia. It is not the primary treatment.
Of course.
Yes.
The cause should be known and then it should be treated
Exactly,
properly.
yes.
Yeah. How can we manage mental health disorders, women of menopausal age? We have discussed so many symptoms, so many things in perimenopausal areas. What do you think? How can we manage these mental issues?
So, as gynecologists, we should be offering hormone replacement therapy. So, who do we want to give it to? Of course, you will take history. You will make sure they have not got any risk factors. But if there are no other risk factors, then women who have had early menopause or premature ovarian failure, they should be offered hormone replacement therapy until their age of normal natural menopause, which is usually 50. So they should receive at least 10 years of treatment, unless it's contraindicated for any other factors. The other thing I want to mention is there is a window of opportunity theory, which means that if you don't give them HRT for 10 years, so say the woman had a premature ovarian insufficiency at 40, and she didn't take any HRT till she was 50. And now she wants to take HRT, or she has come to you and you are thinking, should I give her HRT? Now that 10 years of decline is now of no use to her in terms of taking HRT. So whatever bone mineral density she has lost, whatever cardiovascular benefits she could have got, that has gone. So after 10 years of a gap, there is no benefit of starting HRT. So that is the window of opportunity. So don't let that go. If you see somebody at a young age, do start her on HRT unless there are some contraindications. And also there is a theory which says that if you start estrogens after the age of 60, sometimes it can also damage your healthy neurons in the brain. So the hormone replacement therapy could actually accelerate cell damage in older women. So if somebody comes to you at 60 and they have had 10 years of menopause, then there is no real benefit of starting HRT. I don't think you guys see that many, but in the UK, we see a lot of women because the social media has created so much awareness. Now, women who have not taken it for their 62, they have had 12 years of menopause, and they are coming to see us and they ask for HRT. But I think we have to be very clear that the benefits are lost if we can't give it close to the menopause.
So I think the window of opportunity we all know, and we should offer HRT in earlier. As soon as she has received, she has got menopause, either premature ovarian insufficiency or because of hysterectomy with operectomy. So we should offer it, and if she comes late, like more than 60 years, it's not, there is no benefit. In fact, it will harm.
Yes.
This is the clear-cut message that if we have to give HRT, it should be started as early as possible, just after menopause. So what about non-hormonal medication or treatment? What do you think? Yoga,
yes, so obviously there will be some women who have had breast cancer or they have had a DVT or stroke. These women, you can't give hormone replacement therapy because they are at high risk of recurrence of breast cancer. They may be a BRCA gene carrier. So in these women, your first line of treatment should either be an SSRI, so the selective serotonin reuptake inhibitors, and those that have very severe mood symptoms, you can go for an SNRI like venlafaxine or mirtazapine. So the citalopram, escitalopram, venlafaxine. I quite prefer venlafaxine because it has a good effect on vasomotor symptoms. And you can start with a very small dose of 37.5 milligrams. It helps them sleep and it helps get rid of the vasomotor symptoms.
It's available in our part in India?
I think it should be, yeah. It's quite an old medication.
Okay. We give this serotonin reuptake inhibitors, we give, but I don't know this molecule. What do you mention, the name?
It's venlafaxine.
Oh, maybe, but I have
venlafaxine, yeah.
We give selective receptor modulators, SERMs. I think the same thing.
So they are called selective.
Reloxifene, that is selective estrogen receptor modulators. You are
no, we don't give that for.
We give some in some women.
So mainly for mental health symptoms, usually SSRIs and SNRIs, and venlafaxine is an SNRI. And if they, the main thing is that you have to individualize the treatment. Yeah. Because if they can take hormone, give it to them. If they can't take, you have to go with non-hormonal treatment. Most guidelines say that if somebody has significant mental health disorder, so they come to you in their menopause, but they're telling you that the main symptom is mental health. Then hormone should not be your first line of treatment. Then you have to also give them some form of treatment like SSRI or SNRI. But also don't forget lifestyle changes, because exercise is a very good treatment for mood and anxiety and many of these symptoms. Then CBT is available in India, cognitive behavioral therapy.
I don't know, not in our.
So that is also very effective. It's very effective. But where you feel that there is a significant depression, significant anxiety, you must refer them to a psychiatrist because the condition could be.
But I think, do you think yoga, meditation, because India is a country of yoga, meditation, spirituality, can these help to overcome these problems? Or I think engaging women in certain things. Like if the woman is alone, she can do some social work. She can go to other family member and can talk to about other things. So I think in other ways also we can help them to get out of these mental issues. Not only hormones or not only by giving these drugs. These things can also be of great help, because we have World Yoga School in our part, Munger. Vaishali's parents used to stay here. When her father expired, mother went to Delhi, and here many foreigners are staying here. they are all women are in this age group, perimenopausal transition group, and they used to stay here.
Yes.
I think they are being engaged. They pronounce so good our Vedic mantra in Sanskrit. You won't believe, but they have acquired all these things. So I think,
yeah, but if you look at randomized controlled studies, where because we have to practice evidence-based medicine, the only thing that has shown benefit is your CBT. Nothing else has acupuncture, yoga, meditation, mindfulness. None of these things have shown an improvement with with menopausal symptoms in proper randomized control studies. But so that is important, and I'm sure it helps, but I don't think we have the data because it's not been done.
So maybe it may be available in I think in metros, but not in our part. I have not seen any such center. Are there any specific type of hormone therapy like body identical or conjugated estrogen that are better for mood and cognition? What do you think?
So this is a really good question. I think I don't think we have looked into the different types of hormones to see the difference in the cognition improvement. But I think overall we should look at what is safer for the woman. So I would always go for a transdermal first before I move to an oral HRT.
And that is estradiol valerate or a conjugated equine estrogen. What do you prefer?
So we don't use conjugated equine estrogens anymore.
Estradiol valerate.
Yeah, because they showed quite significant risks of breast cancer stroke. So these days we are using just the estradiol based body, we call it bioidentical, but these are usually available as patches and transdermal
that we also have. Transdermal patches in gel are available in our part also. Okay. What about testosterone? Women are increasingly using testosterone in the Western countries. Is there any improvement in cognition?
Right. Okay. So, women who use testosterone claim that it helps them a lot with cognition. But the British Menopause Society in the UK, they advise that there is very limited evidence of safety on testosterone. Because, for all these years, testosterone has been only used in men. We have not got much data about testosterone used in women. So the only current indication for testosterone in the UK is loss of libido. So if somebody has significant loss of libido, which is affecting them, and it's the primary symptom, and they accept all the risks, then we give them testosterone. But most of my patients tell me that their cognition improves. I will wait for the study to come out where they will say that it improves cognition. But currently, we will not give women testosterone for improving cognition. I don't think we should.
Okay. So what are your key messages? Just this is last question. So what do you want to say to women across the globe, not only in UK, but not only in India, across the globe who are facing this transition? So what are your key messages?
So I think we as gynecologists have looked at various things in women of reproductive age group. So we focus a lot on recurrent miscarriages, pregnancies, on various things in the reproductive time. But we forget that the woman lives half a life in menopause. So I think we really need to look at all our women who are living after menopause and really offering them good support and advice so they can lead a healthy life in terms of mental health and physical health. So as gynecologists, we need to understand the association between menopause and mental health. Every time we see a woman in the menopausal age group, we should evaluate their mental health. We should ask them those questions and we should try and help them with their mental health disorders and symptoms, because there will be many women who will not talk about it unless you ask them. And we know that early detection and treatment of depression, anxiety, major depression, depressive disorders, they have a huge impact on the well-being of a woman. And we should really try to help promote good mental health over the menopause transition. And it's very important that we are alert as gynecologists, and we always consider asking specific questions and screening our patients so that we can provide them with the help. Like you mentioned, you're somebody who died of suicide, sadly. She could have been alive had she had some help at the right time. If somebody had offered help, maybe she couldn't talk to anyone about it. Maybe she didn't seek help. But if we are able to offer that help to women when we see them, use that opportunity to ask them those questions.
This should be in the family. This should be, this support should come from the family only, because no other person can help her. You see at home.
Yeah, I think family awareness will come later, because I do feel that there is a lot of awareness we need to create amongst men about what women go through in menopause.
Yeah.
And there will be many men out there who have no idea about what the woman's body goes through and what symptoms women go through in menopause.
Yeah.
And that is obviously a next step forward, is where, we can empower women, we can impart knowledge to men who should be the support for the women.
Exactly. Either any form, not only husband, maybe her son or her brother, anyone who can think about these problems, these transition, and they can help to get rid of all these things. So I think, thank you so much for joining and giving so much valid inputs about the mental health and menopause.